Okay, so in terms of evaluation, again, I'm emphasizing here, you can see symptom severity and impairment. Another piece I'll be talking to you about is how do we help the child and the family rate the degree of anxiety that's present at the beginning of treatment, and how do we follow that over time. This is in the practice parameter, some of the physical conditions, medication side effects, and at baseline, we need to assess somatic symptoms. When we start medications in a patient, if we don't assess somatic symptoms in the children with anxiety disorders, it was very easy to confuse what they had at baseline with what's happening after they start the medication. And really, honestly, if you don't check it at baseline, you won't know. So very important in anxious kids, they have a lot of somatic symptoms. One of the things I emphasize in this, and I ask every child is, you know, these drinks they have nowadays, those monster drinks, things with stimulant properties. I've seen many kids come to my office, they've got anxiety, they've got depression, they're irritable, they can't sleep, they're not functioning at school, and then we get them to stop those energy drinks and they really look good. Okay, so I feel that that's something right now that we should be asking every child. I've seen it very commonly now, and the symptoms can be quite severe. So there's a lot of things in the differential, but that's something that commonly I see nowadays. Okay, so what I'm wanting you to think about here are these measures. How are we going to measure these symptoms? Now, we use a feelings thermometer from the ADIS, which has 8 thermometers on it. That's copyrighted, so I didn't put it in this presentation, but just to give you a sense of what a feelings thermometer looks like. You see at the bottom, we've got things are peaceful. We've got piece of cake on this, meaning that they're trying an exposure and it's easy for them to do it, no problem. And then you get all the way to, oh, I can't take it anymore, it's out of control, okay? So they're going to be rating each of their symptoms on this thermometer, but in addition to that, you want to be rating the severity. How impairing is it? So questions such as, well, how much does this make it hard for you to do things you like to do? How much is this messing things up in your life at school, at home, or in the community? These are the kinds of questions you can ask and helping them to rate how much is their anxiety impacting their life. For younger children, we use something like this feelings barometer. I actually have children who are younger but also who may have developmental struggles. I have them maybe draw faces. Let them make their own thermometer, something that's meaningful to them. You can use colors, you can use anything, but something meaningful to that child so that they're going to be able to rate their anxiety level. This should be something we establish at the beginning of treatment and then follow with them and the parent over time, no matter what treatment intervention we're putting in place. Okay, this next section I'm just going to have to breeze through, but I've given you a lot of slides. This has to do with the different anxiety disorders. I've given you what are some of the symptoms more from a clinical perspective. So we have separation anxiety, where you have excessive fear and distress. One thing to emphasize there is just in terms of the focus there for the child is often things happening to the caregiver when they're away. So their nightmares tend to focus on bad things happening to their parents. They're going to get sick, they're going to die, something bad is going to happen. They often have a lot of physical complaints. They're often sleeping with their parents. Generalized anxiety, they're just worried all the time. So I often describe it as a big, heavy backpack full of worries that's just weighing you down. You feel tired, and you can't get rid of it. The moment you wake up to the moment you go to sleep, it's there with you. Okay? These are kids are perfectionistic. They want to please everybody. They want to do the right thing. A lot of times, unless we're giving them the scared or the mask, we may not know that this disorder exists because they're doing great. Everybody loves them, okay, but they're really struggling. So again, I've given you some more things. They commonly have somatic complaints. Then we come to social anxiety. It's not just a discomfort in social situations, but it's a sense of embarrassment. You think you're going to look stupid or dumb in front of your peers. You think you're going to make a mistake. People are going to laugh at you. These are the kinds of things they talk about. One of the things about social anxiety is it affects your ability to communicate. It affects your ability to make friends, join in on conversations, a lot of skills that are required every day. So I've given you some more information about this. One of the things about social phobia is when we are working with young children, they may not have the ability to talk about embarrassment or these kinds of experiences aren't something they understand yet. It's important to assess Are they uncomfortable, and how uncomfortable are they, and is that discomfort keeping them from participating in social situations, going to parties, having play dates, things like that? Because one of the challenges I've seen in our clinic is sometimes our trainees will not give this diagnosis because they can't specifically see embarrassment, or they can't specifically see the criteria in DSM. You know, I think we do these kids a disservice, because if we identify this early, we can really start treating them early. And this is something I see, I'll be honest with you, in preschoolers. I work with a lot of selectively mute children. A lot of times we're led to think this is onset in adolescence. I think this is something that's present often in the child's life from the beginning. Specific phobia is the same as in adults. I've given you some information with panic disorder. This is another one where initially in children we may see them having panic attacks, but we may not see them actually being able to say that they're having panic attacks out of the blue. All right, I'm going to have to keep going. Selective mutism I love, but
I think please remember the meds.
Yes.
Meds.
Yes, so I'm just going to, probably what I'll do here is I'm going to go ahead. The one thing on the aggression slide I wanted to mention is that we want to think about, again, I mentioned how anxiety can show itself as oppositionality, even aggression, and we don't want to misdiagnose that as something else. That's a big part of what I wanted to mention in regard to aggression. The other thing is if the child's anxiety is severe and we start CBT or another psychotherapy and ask them to do exposures when they're not ready, then they can get quite aggressive. So those are kids that we really want to be thinking about using medication in order to reduce the severity before we start pushing them to do things they're not able to do yet. Okay, so one of the ways to understand medications is that if a child has mild anxiety, this is also the practice parameter emphasizes, this is what we see in the evidence. We need to start with CBT, we need to try CBT, and then we determine if they get a partial response, an inadequate response, and then it also helps us to see if they're going to be able to handle, like I said, psychotherapy and exposure, or if we need to use medications first. With more severe patients, we often need to start the medication right at the onset. I'm just going to keep going here. So one of the studies that's helped us to understand this combination treatment is the CAMS study. I think you may be already familiar with this, but one of the things that they did in the CAMS is they compared CBT alone to sertraline alone to placebo for the sertraline. There wasn't a placebo for the CBT, and then to the combination treatment. And they really found that CBT and the sertraline worked both well for separation anxiety, generalized anxiety, and social phobia. But when they combined the two, they had a much better result for kids in this study who are moderately to severely impaired. That's the population they were looking at. So I think that's an important point out of this. The other thing they found in this study, though, and they had to emphasize, was that, again, CBT is not available everywhere. So again, these decisions have to be made based on what is available to the family in any given place. One of the other things is they did not find significant suicidal ideation or significant untoward effects in the study. This is a large multi-site study. So what we like to say, as I said before, is if CBT is available or is not available or not feasible, we at least want to do the psycho-ed, we want to do parent training, and we want to do case management, often with the school, to see that the school is also understanding what's going on. So I've just given you some information here on CBT and how it works. There's identifying and monitoring the symptoms. There's the psycho-ed piece. We've covered that. Then there's somatic management, relaxation, guided imagery, diaphragmatic deep breathing. Then there's a cognitive restructuring, which has to do with challenging negative thoughts, helping them actually even bring into their mind positive thoughts, way to cope with the anxious thoughts that their mind is generating. Practicing skills, role-playing, these kinds of things, and then exposing them to the anxiety-provoking situations and using the skills that they've learned. Okay, so I'm going to skip over some of this, and I want to get into the SSRIs in particular. These are the only meds we have that have really shown efficacy in numerous trials. Okay, so these are some of the things that we want to be thinking about. We want to think about what's the comorbid disorder, what are we going to treat first. We want to think about involving the family, talking about the black box warning. We want to assess, I mentioned to you, somatic symptoms at baseline. And then in terms of SSRI, I'll talk to you about which medicines have at least had studies that have shown efficacy. But at this point, we haven't had head-to-head studies that compare different SSRIs, so that's something to be aware of. Okay. There's no clear guidelines when more than one medication is needed to manage anxiety disorders, but I'm going to try to give you some information to help with that. In young children, we should start at lower doses because we find lower doses are going to help. And I've got a slide I'll show you today about what doses to start with. The recommendation at this point is kids remain on the medication for a full year of good functioning, not when they start, but good year of full functioning. And then we can start slowly decreasing the medicine a step at a time and see if they can be on a lower maintenance dose or they can come off the medicine. The studies show that if you have CBT and medication treatment, then when you take the child off medication, you're more likely to be able to come off the medication and have the symptoms still be improved. If you don't have CBT or other treatment interventions in place, you're likely to start developing the symptoms again and have to stay on the medication. Okay, I've listed side effects of the SSRIs. I think we can review these later, but I think these are familiar to you. Some of the things to think about, though, are we want to look for more severe behavioral activation because that can be a factor if kids are impulsive. That's when we have to worry about also if there are suicidal ideations, they may act on those, okay, or they may act out aggressively. And then we also want to think about disinhibition. And that's even in younger children that becomes more prominent. That's when they start acting. This is an anxious child that's trying to do everything right. All of a sudden they're lying, they're cheating, they're yelling at their parents. They're saying, well, I don't care about that anymore. Whereas before they were trying to do everything right. And so it's fairly evident to parents when this is going on. And it's something that we want to be aware of. That actually can be dose related. So we're able to deal with that. We're also able to switch to different SSRIs. In younger children, we find that activation and vomiting may be even more common than in adolescents. With fluvoxamine, they've actually been able to show that children seem to have a higher dosing effect, that they need a lower dose to obtain the same effect as adolescents. And we're finding that in many of the SSRIs. And again, behavioral disinhibition was noted in some selective mutism studies with younger children. So I'm giving you some examples of dosing here. For example, with fluoxetine, we can start as low with the liquid as 0.5 milligram or 2 milligrams a day, okay, and then going up to 5 to 8 milligrams. 5 to 8 is one of the guidelines set by the work group in ACAP for the young children. Sertraline, I've given you some starting doses there, okay? And again, we look for activation and behavioral disinhibition. This is the preschool guidelines I mentioned. They actually asked us to consider fluoxetine as a first line because there were some studies, at least with young children. The CAM study has come out since this guideline came out, so they had evidence for fluvoxamine. That's why they said that was second line. But now we've got the other study, the CAMS as well, I think that gives a little more evidence for sertraline. But they did not in the CAM study look at young children who are 6 and under. This work group recommended not using paroxetine, not using the TCA's alpha agonists. They also cautioned about benzos because they really feel that they have important effects on cognitive skills in young children, except for dental or medical procedures.